Hello, everyone, and welcome. My name is Samuel Konstanty, and I work as a data scientist at Loopback Analytics. This session will detail how we have used John Snow Labs pre-trained models to abstract clinical notes to develop and track relevant endpoints for rheumatology patients. To outline this presentation, I'll start with a very brief overview about what we do at Loopback and describe the driving force behind this work, which is the Therapy-Specific Outcomes Coalition, or TSOC. I'll then describe two separate use cases for which we have used John Snow Labs models, the first being extracting joint pain locations from clinical notes, and the second, extracting patient-reported pain scores from clinical notes. Finally, I'll summarize how this work benefits our clients, which are academic medical centers. And then I'll finish with some challenges we experienced in this project and some lessons learned. So to quickly summarize our work here at Loopback, we are an analytics provider for health systems and academic medical center specialty pharmacies. Our data platform contains EMR and pharmacy dispense data from over 40 clients and over 50 million patients across the United States. Our health system clients are focused primarily on the treatment of specialty patients, who are patients with very complex or very rare and chronic disease states that require either extremely high cost or limited distribution drugs and can be extremely challenging and costly to manage. Loopback's goal is to provide insights to these health systems in order to improve patient outcomes and aid in providing superior care, and thereby supporting the claim that health systems can better manage these specialty patients than big box chain specialty pharmacies due to their integrated care model. One challenge in actualizing this goal is the lack of standardization of data in the healthcare space. There are numerous and disparate data sources across health systems with completely different data models, and sometimes this data doesn't even talk to each other. And each client may track a different set of outcomes to monitor the performance of their treatment plans. So it's very challenging to benchmark a process if each client is doing a slightly different thing. Because of the variability in data across different health systems, Loopback Analytics is uniquely positioned to be able to provide standardized outcome measures through our data platform, which can benefit patients, the health systems, and manufacturers. For this reason, last year we founded the Therapy-Specific Outcomes Coalition. TSOC is a collaborative initiative between Loopback Analytics, Acentrus Specialty, and currently 14 academic medical centers across the United States. This initiative aims to develop real-world evidence for best practices in managing these patients with rare or complex disease states. For each therapy of interest, subject matter experts within the coalition collaborate to identify the most relevant clinical endpoints to monitor the outcomes of patients. Once the set of endpoints is finalized, then we calculate these outcomes and endpoints and provide analytics and insights back to the health systems. The goals of TSOC spread across many different stakeholders. As I've said, this initiative aims to improve patient outcomes through a data-driven approach for best practices of care, and also allows pharmacists to track which patients are not responding well to therapy. Also, TSOC benefits health systems by helping them gain access to payer networks, so these pharmacies would be able to fill limited distribution specialty drugs by showing that they can manage patients equally to or better than the big box pharmacies, and thereby lowering the total cost of care. Finally, this work aims to develop large-scale real-world evidence toward clinical research around which drugs or which processes are performing the best in practice. TSOC has committed to develop endpoints for 8 different therapy areas by the end of 2023. And last quarter, we just finished our work on rheumatology, which is what we'll be discussing in this presentation. We required endpoints from lab results, hospital utilization, prescription adherence, and disease progression. However, a lot of the necessary information pertaining to disease progression for rheumatology is found in unstructured clinical notes. So we had 2 separate NLP tasks to abstract this important information. So our first use case for NLP was to extract joint pain locations from clinical notes. One of the most used assessments in determining progression of rheumatoid arthritis or any other rheumatology disease is this CDAI questionnaire or assessment, which is known as the Clinical Disease Activity Index. This assessment yields a score from 0 to 28 as to the number of joints that are either tender or swollen. Tracking the severity and location of joint pain can help providers assess disease severity and also quality of life, as well as serve as a reference point, a numeric reference point for tracking the state of the disease throughout therapy. So to simplify our problem, we grouped pain, tenderness, and swollenness into the same concept. So our task was to determine for each clinical note how many distinct joints were affected within the fingers, the wrists, the elbows, shoulders, or knees. So the input to this process would be a clinical note, and the output would be a number from 0 to 28. To solve this problem, we used JSL pre-trained models with the following process. First, we gathered each patient in our rheumatology cohort for each client, and then we filtered all their notes for any note with a rheumatology diagnosis or a note that mentioned pain, tenderness, or swollenness using regexes. We then fed those notes through the JSL pipeline with the following stages you see on the right. We started with the typical stages, the document assembler, the sentence detector, word embeddings, and then our testing showed that the NER radiology named entity model would function well for our purposes as it's successful in identifying body parts and symptoms. So we filtered the output of the NER model for only the entity types of body part, symptom, and disease. We then attached an assertion stage to retrieve assertion information to help us figure out if joint pain was not present. Obviously, if the note simply says, patient's joint pain has been improving tremendously, we need to know that assertion status. Finally, we used the RE body part problem relation extraction model to connect the body parts to problems or symptoms or diseases. Then the output of the JSL pipeline was post-processed to develop a single feature for each note, that number from 0 to 28. And then those features were aggregated within a patient's therapy dates to determine the progress of the disease. So in terms of post-processing, we first had to filter the JSL output to only save symptoms of interest, namely that regex that matched the concepts of pain, tenderness, or swollenness. Here, each row represents one relation between one symptom and one body part. But we needed to get the distinct number of pain locations for each body part chunk of text. To do this, I aggregated the JSL output across each body part and used some regexes to determine if the mentioned body part chunk was singular or plural. For instance, left wrist represents one wrist that was affected, but bilateral knees or both knees or each knee represents 2 body parts affected. Same goes with the fingers, since there are 10 different joints on each finger of interest. Once I got a score attached to each relation for how many body parts were affected, I could aggregate each row within a single clinical note to sum up the distinct number of joints affected and save off a distinct list of which joints were affected. So this final output table represents the final abstracted feature. So for note 1, eight joints were affected: 1 wrist, 2 knees, and 5 fingers. A count of distinct joints affected is essential because a single note might mention left wrist pain 4 different times, but that does not equate to a score of 4. Once the pipeline and post-processing was tested, we took a random sample of 200 notes from our relevant corpus, and the performance of the full pipeline, including post-processing, on our sample is shown at the bottom via manual verification. On our random sample, we attained a precision of 87% and recall of 82% for an F-score of 84.4%. We would like to improve the F-score on a future iteration of this project by training our own models with data from many different clients. Part of the difficulty we encountered in building a confusion matrix for a problem such as this is the fact that a true label is not always known. For instance, if the note only states the patient's joint pain is spreading and getting worse, there's not enough detail to know exactly which body parts are affected. So we decided to give any note that mentions joint pain but doesn't specify a single location. We would give that note a score of 1. Once these notes were abstracted, they needed to be used towards an actual clinical endpoint. And so to do so, we gathered the dates for each room patient's therapy and determined the maximum number of joint pain locations at the start of a patient's therapy, and compared that number to the maximum number of joint pain locations near the end of the patient's therapy. If the number of joint pain locations increased over the duration of the therapy, we stated that the disease is progressing. But if the number of locations decreased over the course of the therapy, we stated that the disease was in remission, or else it is stable or no change. One challenge in this approach is the fact that a note with not much detail might be abstracted to a low score, when in reality, the patient might have been in a lot of pain, but the note just didn't have much detail around that pain and didn't mention many body parts. Even more challenging, if a patient doesn't have any notes recorded near the end of their therapy, we can't simply infer that the pain has gone away solely because of the lack of data. So a true score of 0 is extremely difficult to infer. We've developed this dashboard to provide to the AMCs to quickly view the patients that are progressing, in remission, or stable, to be able to determine which drugs are working the best, and also to provide the ability to follow up with patients who aren't improving. If we look at these 2 bar graphs in the middle of this dashboard, we can quickly show that 11 out of the 13 patients with a room therapy being managed by the client's pharmacy are improving, and only 2 are worsening, whereas only 30 out of 39 patients being managed by an external chain pharmacy are improving. In the future, we would like to add some tests to determine statistical significance between various cohorts, as these types of insights are essential to back the health system care model or back which drugs are functioning optimally. So the next use case we had was to extract patient-reported pain scores from clinical notes, as this data wasn't stored in structured fields for many of our clients. Different clients use different methodologies or questionnaires or assessments to determine patient-reported pain levels or quality of life measures. So we needed to extract scores from 8 different assessments. 3 of the most common of these are called rapid 3 scores, CDAI scores, which I previously mentioned, and global scores. The task is to extract from a clinical note the test name, test result, and test date from each clinical note. To do this, we actually used the RE test result date relation extraction model, as the syntax of this information we need is very similar to the syntax of lab results. So in a very similar process, we first gathered the same cohort of rheumatology patients we were interested in and filtered their notes for any note that mentions the 8 different pain score assessment names that we were interested in. And then we built the JSL pipeline in the following manner on the right. We used the JSL NER WIP clinical NER model, filtered the output of that stage for only the test result, and date entity types, and again used the assertion DL model to remove absent assertions. And then finally, we used the RE test result date relation extraction model to link these entities together. Once the notes were passed through the JSL pipeline, some post-processing was done to ensure that only one test result was associated with one test name, as sometimes the relation extraction model could create a cross product of relations if the max syntactic distance parameter isn't properly set. For instance, in this sample note, we didn't want to connect the CDAI name to both this score of 49 and this score of 810. So each test result was only attached to the closest name to it. Further, the chunks were normalized to standard terms. So each test name chunk was standardized to one of the 8 assessment names of interest, and the extracted dates were normalized to the same format using John Snow's date normalizer. For instance, we need to map this 3/1/22 chunk and this April 3 chunk to the same format of date to be able to use this for analytics purposes. Finally, the features were filtered for sensible information. For instance, if we know that global scores should range from 0 to 10, and a global score was connected to a value of 47, that record was thrown out as that feature would be illogical. For this reason, we made the design decision to maximize precision at the cost of recall to ensure that the features we're saving off and displaying have a high confidence of accuracy, even if we're losing out on some of the false negatives. Finally, since each relation extraction output connects only 2 entities together, I flattened this table to map the test name, test result, and test date to a single row or a single record. Again, in a similar fashion, we used a random sample of 200 notes from the corpus, and a manual review of the pipeline output showed a 91% precision on our random sample. And again, models trained on our own data should increase the performance of this in the future. Similarly, to demonstrate how this data is being used, we built endpoints around the delta between the first and last pain scores within a patient's therapy. If the pain scores decreased by 20% or more over the course of the therapy was considered improving. While if the pain scores increased by 20% or more during the therapy, it was considered worsening, else it is stable or no change. This dashboard presents charts for each of the 8 pain assessments of interest, so the user can click on the pain assessment they care about, and all the charts will update with scores from that specific assessment. Again, these 2 bar graphs in the middle are extremely important to compare the outcomes for the client pharmacy versus external pharmacies. Again, as a way to help prove out that the AMCs can better manage outcomes. Further, this bottom left chart seeks to demonstrate that adherence to medication should improve outcomes and pain scores. So this chart is showing that the delta in pain scores versus adherence to therapy, and we would expect that the patients with higher adherence would have a negative correlation with the delta pain score. The user can also click on any segment of this dashboard and get a list of patients in the category that was clicked on in order to track patients for that specific cohort and get more information about them, maybe explore a regimen change or a dose change. To summarize all the benefits to the AMCs with this NLP functionality that we've discussed, first, this automated process to extract relevant information from clinical notes significantly reduces the need for manual chart review. Health systems typically use residents or fellows to complete manual chart review for research purposes, and this process would decrease the labor burden on them. The dashboard that we provide also allows pharmacists a tool to quickly prioritize and identify patients who may not be responding well to therapy. Also, this information can be provided to the client in a de-identified manner, which enables health systems to use the data for an expedited IRB process, alleviating some of the administrative burden associated with conducting research studies. As stated in the introduction, the entire point of this initiative is that it allows collaboration across different health systems to determine best practices. And we are currently working on a benchmarking product for comparative analysis across different health systems. Finally, this product provides clinical research to compare the results of competing drugs or biosimilars against each other. Finally, the challenges in this project were similar to most NLP tasks. First, it is difficult or accurately abstract clinical notes that lack detail. As I mentioned earlier, if I'm trying to determine joint pain locations and the note just states, this patient's joint pain is worsening, we can't quantify the severity of the disease with a score if the notes lack detail. Also, since our clients use different assessments to quantify pain scores, some clients may only use CDAI scores while others will only use RAPID-3 scores. It's difficult to determine best practices and benchmark outcomes if some data elements are not present for different clients. Finally, since each provider documents clinical notes differently, it can be challenging for NLP to be accurate due to this variability. One example I see a lot is a majority of the providers will document data in the form of they'll list the test name first and then the test result second. And then other providers list the test result first and the test name second. And it's very difficult for a standard NLP process to know which result and name to connect to each other. Overall, though, we found success using JSL as pre-trained models, despite this variability, using a little bit of post-processing. It was a huge success that we could use pre-trained models for slightly different purposes than what those models were trained for. For instance, using the NER radiology model to identify body parts and symptoms for rheumatology. But ultimately, it's probably necessary for us to train our own models in a future iteration of this project to improve accuracy for our specific use cases. Thank you to everyone who listened to this session. We're excited to continue to use John Snow Labs for future TSOC products. We're currently working towards a cystic fibrosis product, and we've begun starting work on an oncology product. So we're looking forward to incorporating many different JSL tasks in the near future. I've attached my contact and a link to our website. So if anyone has any questions, feel free to reach out to us or post some questions in the chat. Thank you.